one question was answered.
Yeah, I saw.
So the proposed rule came out, and it became clear that the entity itself is defined by the participating physician. So whoever goes on that participating list is now going to count towards that 25% of attributed beneficiaries that you need to hit. We thought it was going to be by the physician, and instead, they thought if you aggregate together, there are going to be some doctors who are just not going to quite have enough, they're going to be have a bunch. But if you put them all together, you have to hit the metrics. That seems more fair, not unreasonable. But if we realize that, on the one hand, we wanted to be very collaborative with our specialists in the community, but the more specialists in the community that we put on our participating list, they would be taking care of patients that would be referred to them by external entities that weren't in the next generation ACO. And those patients wouldn't count. And suddenly we realized, wow, we're really nice and we put them on our list. We all may not qualify for being an APM. So we need to eliminate all of them. And then came the certified health record. Not everybody's on an electronic record, so we're not going to put you guys on the list. And so we dramatically curtailed who was on our participating list this year with the expectation that there's going to be a shrinkage in the number of distributed beneficiaries. I didn't tell you, actually, the first year we were worried about hitting 10,000. We budgeted for 12,000 and set a preliminary number that we were going to get 18,000, and at the end of last year we were told we had 25,000 beneficiaries. So we budgeted for 12 and 25. With this change, we expect that probably to come down closer to about 12,000, 14,000 line beneficiaries, closer to where we want to be. The other thing, by having the alignment through physicians that were not in our organization, it takes away that connection that you have to those patients. So taking care of patients nowadays is a team sport. It's not just you come in, the doctor takes care of you, knows everything, and then you leave. There's a whole lot of stuff that needs to get done, and it really doesn't need to be done by the physician or the clinician, the practitioner. And to have that team do outreach when the person that patient thinks of as their primary care provider is not related to you, how do you do that? And it really would inhibit you. So we realized the physicians on our participating list really need to be the physicians in our medical group and in our IPA. And we have just a handful of physicians that are not in our medical group or IPA that we left on the participating list just because of the relationship that we have with them. So that's where we ended up on that list.
Great. Thanks. Thank you. Question over here, and someone's got the microphone.
Your strategy and system. I'm personally deeply concerned about the growing Medicare population. I'm sorry, I'm part of those folks. What I see is that a lot of small groups that do take care of a lot of people, especially in rural areas, in other counties, so that also are just San Diego, San Francisco, LA-based counties. There's a big washout because it's lost. What I see the memorial is that they aggressively want to have that Affordable Care Act. It created a group model, it created an IDA model, and it's a 900-bed hospital, it's owned by the main hospital, and the other hospital certainly has a vested interest in having a sufficient medical staff to provide care to the size of the institution it becomes. What are you going to do when all those people are not able to access the science assistance? What's the alternative strategy that the system has focused on the rest of the medical community that we all really need?
So I can focus on the communities that we cover, so the areas that are more rural, because for the most part, the areas that our organization covers wouldn't fall into rural. You see across the country a lot of large systems absorbing physician practices with the goal of moving that outpatient work into the hospital so they can make as much money in the last few years, but they can't. And even in places like Southern California, you still see that happening. It's against what is being proposed, it's against where everything else is going, but that is still what we see a lot. Do more for inmate patients in the hospital as you can. That has not been the focus for Memorial Care. So one of the things I noted in our foundation, we put in freestanding imaging centers, and we've actually redirected a lot of the imaging out of the hospital into the freestanding centers. You can charge 150 to up to 500% more for the same study, same quality done in the hospital. Instead of them out the freestanding center, we made that choice to move it out. Our ambulatory surgery centers, same thing, put them in the foundation, separate it out, and are actively trying to move patients out of the hospital into the ambulatory centers. Again, it's a loss to the hospital, but it's the right thing to do. That is really where those outpatient cases should be going. And we started seeing on the Medicare side because we can't yet, but on the commercial side, patients getting total knee replacements, total hip replacements. Those used to stay in the hospital for a few days. We're doing them in an ambulatory surgery center, they're out within a day, and they're home again. Much better for the patient, much more cost effective. So the Memorial Care as an approach for the organization has been what we do to improve the quality that we provide, the experience of the patient, and to reduce the costs. So that tripling really has been the goal of what Memorial Care is doing.
I'm trying to be glad I did describe those quite well enough. It boils down to this. We're a major system, and you have to support the community and the nonprofit. This is a community responsibility. My question is, I understand a lot of course, efficiency in delivery services, one outpatient model, I'm going to help one thing that myself.
necessarily answer the question completely. There are a lot of things that we do for one of the more needy communities that we have is the Long Beach area, and we do have offices like our primary care offices in Long Beach that cater to the Medicaid population, the needy population. That's where they get their care. A lot of them get it through our clinics in the Long Beach area. But I cannot at this point just elaborate on anything greater to the more rural communities that we're going to provide.
Correctly, please, real fast. The state is working with the Council Grant to the Vision Care on accountable communities for health models. And this idea of, which I think is what you're getting at your question, if I understand correctly. I think the way you're posing it, what the systems do to generate this greater community organization for delivery of healthcare and integration of services. The state is actually working on models that they're piloting in a few locations under the Council Grant to develop this kind of an approach, which of course we pulled out of the Hotspotters article and even going back to the cost conundrum as well, and places like Burning in Colorado. So that kind of work is underway. Primitive at this stage, sustainable models haven't been figured out, but there is an effort to do it, which I think is great. Is that working for your question? There is a plan. I mean, there is activity going on to do that, to address that issue.
The problem really is, though, is that it's very expensive to live in California. When we lose this next generation of physicians and other providers that are affiliated with those physicians, we're going to wipe out another of the market that's an aging growing population. It's very worrisome. And what I see is that frankly, the Obama administration, I'm not an affordable care pastor, I'm actually, generally speaking, think that it's a necessary piece of legislation that of course needs to be updated and upgraded somewhere. That said, where it seems to me that we were going to, we had a hospital-centric system. We had a system where the large facilities had built large programs. It's not really correct that in some places they take the oxygen out of the area. That's very true, Dr. It's very true. So really the question is, what are these systems doing? Because the people that are going to be working there will not be able to handle the volume of patients, and we will have, as you schedule, Dr. Lee, somebody coming in at 2 a.m. because they're measured. This is a crazy thing. It's obviously predictable. I'm Jack Leno, as the chair of the Department of Health Management. Thanks very much for really interesting insights into how the organization is responding, but I really appreciate the word on that. I'm going to talk about it with background because some people in the group don't have a deep appreciation of all the moving parts in this work with the kind of the National Quality Forum and the Quality Resources Measures. And to comment by Dr. Lee that we're not, resources measures, they're not resources measures, they're very accurate. But we understand best prices. So you can't actually earn anything by reducing the resources you use to produce a service. You can only get cost savings by changing the mix of services, keeping patients out of the hospital, possibly cutting other services. So the shared savings model is implicit in these basically shifting and changing the kind of services that are open. And that's where people started in business. But then we concerned about thinking about patients not getting valuable and needed care, but the cost will look great. So we need to add something to people who can't get less. Polymetrics became part of these programs. So now you've got the polymetrics, it was not another building infrastructure to do that, so now there's LIC, minimum services that are also part of whether or not you get paid under these. And then of course, there's concerns that polymetrics, some which do well, some which do less well. Additional physicians do it better than others. And you get the ones that don't get what we discouraged. We now have another set of measures around quality improvement activities, regardless of how well you're actually delivering high quality care. And those four components become the long list of measures that physicians get to choose from as they're trying to install those new measures. That's all I want to do. And I can easily see physicians throwing up their hands saying, oh, I just did a report, because I don't report anything. But let me report. None of these practicing the way I've been practicing and just move to the next. So my question for Bill, my question for Jay is how are the physicians that you interact with responding to this? What have they respond to these incentives? And what hope are they getting to actually move themselves along to where they're simply not reporting the data because it's required, but actually trying to improve practice of those four dimensions that is ultimately the. Well, as we said, most physicians, most rank and file physicians, don't understand the magnitude of this rule and are not prepared for this. And so CMS has pushed off the qualifying periods, and it's going to be a longer trajectory before some of the sticks hit in private practice. So you're absolutely right. A lot of our frustration with the administration in this rulemaking process has been that it looks reasonably good on paper, but in practice it is really but it's not it's very difficult to operationalize. And we have
have a model here in California that goes back 15 years, the IHA paper performance system, which was a collaborative model, which has evolved over time and taken the level of practice from point A to point B in pretty direct fashion. We had hoped that we continue to lobby, based on the experiences that we've had in California with that type of model. Our frustration in CMS has always been that they continue to hold back more advanced systems, like fully capitated systems, and they could probably help individual doctors to qualify to practice. And that's our biggest frustration with the entire ACO program today, is that it's too permitted for California, for places like California. It doesn't take into account some of the models that we've worked on to relieve pressure on individual physicians, and to let larger organizations work out the qualifying details and do the reporting. And so we continue to lobby on that.
From my perspective, I think what we're seeing is a market response to this in some ways. And for example, in the family medicine community, there's a growing number of physicians that are actually coming out of the insurance system altogether and doing direct primary care, which is a subscription model practice. So now, is that the answer to serving the health of the entire population? Probably not, because the panel sizes are much smaller, and they will, in fact, provide more personalized, potentially even better care that may or may not involve data. But in terms of the patient sense of value from that care, having access to a trusted physician or a trusted team of providers may be part of the answer to that. So I've certainly seen folks react to this idea of being measured, so to speak, by moving in that direction. I do think that there are going to be a lot of SMOs, since I'm on the back, maybe we'll stick with it. SMOs who will look for ways to partner either with others in their community in these virtual groups. So it's nice to see that that's certainly an option to kind of, spread out the administrative burden of those reporting requirements. And I wasn't kidding. I really do think there's going to be a market for consulting companies that do this for not just large systems, but I think for those small and solo practices, because the burden cannot be borne by those individual practices because they just don't have the infrastructure to do it.
So what I heard both of you say is that we should people that is let's throw our hands get up rather than trying to find ways to response to incentives on that and following activity.
No, I think that there are going to be some who do take the route of, well, I'm not going to accept Medicare patients and just go down the PC route, and certainly seen that. But I do think that there are people who really truly believe in this value over volume model because they've been on the hamster wheel for so long, and they see that they can't, even if they've got data, they see that everything's plateaued. And usually what that means to me when I'm looking at that is that the individual effort of trying to make some of those measures improve has exhausted its ability to create change. And so then you have to actually create systems of care, which is either through an integrated system or through a virtual group or an MSO type organization in a rural or underserved area to help with doing the administrative piece of this. And so it's sort of a chicken or egg thing, right? Like, are these practices really going to try to do this on their own, or are they going to wait for these organizations to help us give them the technical support that they need? And the answer is probably both. they really have to wait, and it's very uncomfortable. Because you listen to the stories of down on the ground, it's very, very uncomfortable. There's a lot of uncertainty about how to solve this.
The one thing I'd like to just point out is that the program that they have that they just developed here, it seems completely new, but it's actually just an evolution of what they've already had in place. So meaningful use is expectation that physicians will be using certified electronic health records technology. They initially start off with incentives, and those have escalated to the point now that if physicians aren't submitting for meaningful use, they're potentially subject to a 4% penalty. And submitting the quality data, PQRS, has been in place for years. And those penalties, there's no incentives. If you don't submit your PQRS data, 4% penalty. And they started the value-based modifier. That's just hitting the small practices now. 9 or fewer physicians will get an adjustment in 2017 based on the services they provided in 2015. If they didn't submit PQRS, they're not going to get the value-based adjustment. And that's another potential. That's another one of these balanced adjustments. That's another 4% hit. So potentially, physicians next year, 9 or fewer who are not prepared, are going to get a 10% reduction in their Medicare payments. In 2017, 2019, before MACRA even hit, actually MACRA ends up being a relief because they're the maximum penalty is 4%. Instead of the 10% that they're going to get hit on, with the way things are currently.
Scott, over here. Microphone.
Graduate of this program. And a classmate last week. My question has to do with community health benefits. Today's learning about a record down at the best. Even though CHC said we are the community in fact wants to order Jay and Bill will comment on that. Bill comment that's what we are. This law, this reg is huge. It's a concept. Because we're way ahead of it. So maybe comment on how this might affect the work that's what we bring to the board and especially together.
Absolutely. So the board of and when they're sick, they come and they're seen and we take care of their needs. I think since people have their insurance card, it's changed a little bit of the nature of the business of community health centers in ways that I think are moving us more towards this value-based type model, meaning there are Medicare capitated lives, which is new. There's this idea of, I know particularly at Venice, there's been a real growth in the use of data for decision-making in the last 3 to 4 years since the advent of the Affordable Care Act, thanks to the talented people that we have working the data mines, if you will. And mentioned the CP3 project that CPCA is California Primary Care Association is spearheading. It's modeled in many ways, and the sort of congruency in 3-letter acronyms of APM and APM. I don't think it's accidental. I mean, I think there's some, I don't know who devised it, but it makes sense that that's what they're calling it, because the truth is you can't survive on this volume alone. And so I think it's requiring community health centers to build infrastructure in ways that they haven't needed to in the past. So in the last 3 years, we've hired a QI manager, we've hired a population health manager, we've hired a PCMH manager, and this is sort of new business, or a new business model, if you will, for community health centers. So I think in a way it's going to, it's sort of interesting because I think the ACA has been a boom for community health centers. I mentioned Eureka. In the last 3-4 years, the community health center there has burst. It's really grown up because of the additional business and the subsidies that come from the government. And so I think in response to that, we're going to need to be able to deliver on that AAA promise, but it's going to be challenging because on the one hand, we need to maintain a certain amount of volume because the payments are still very much model profit fee for service. And on the other hand, we have to move quickly towards value. And if the need for the acceleration is mismatched, that can be potentially disastrous. So it needs to be well managed and strategically implemented. And so that's what the challenges and opportunities that they continue to have. Correct, yeah. I think we're about 5 years now. Any other questions here? Oh, right here. Adam alluded to this earlier, but I think this idea of team-based care is really critical to meeting the demands of the population because you can't just grow doctors fast, and you can't grow them fast enough, right? And of course, the truth is, there's a lot of lead time to create different professionals who are involved in patient care. I'm often surprised when I meet clients who are literally ordering supplies, and I think about how underutilized their skills are, and then I think about folks like Tom Rosenheimer who would say, well, our insertion is order supplies, they should be helping the population doing teaching the leaders who are on the front line and providing the care that's needed. And so this concept of people working to the highest extent of their license is one that I don't think is leveraged enough.